Hi, my name is Alvaro Alencar. I'm a member of the Lymphoma Program at University of Miami Sylvester Comprehensive Cancer Center. We're here at ASCO 2019, and over the next few minutes, we're going to review the most important abstracts on hematologic malignancies that have a more direct impact on our daily practice starting next week. On Saturday, in the leukemia session, there were three abstracts that were particularly important. They were all two of them were phase 2 studies, but still demonstrating very important signals on the treatment of acute leukemia. First is a phase 2 study evaluating CXO1, which is a heparin derivative that doesn't have any anticoagulant activity but has demonstrated important activity on the CXCR4 axis, which is directly related to the homing of leukemia cells in the marrow. In that study, it was a phase 2 study randomizing between three different groups. A standard of care group was induction with 7+3, and two different groups with CXO1 added to 7+3. This agent had previously been evaluated in younger patients undergoing induction for AML, demonstrating important activity, and this study evaluates specifically the population of older patients that are still eligible for induction therapy. What we see in this small phase 2 study is that there's a clear signal of activity of CXO1 in acute leukemia, and this is seen mainly in the patients that received high doses of CXO1. There were higher response rates, some suggestion of greater progression-free survival and overall survival, but there were a lot of important caveats in this study, a lot of dropouts there, but seemed not to be related to toxicity. In fact, toxicity was not increased significantly with CXO1. So there's a signal that maybe the addition of this agent may improve responses, and we're going to see more of this agent in both young and old patients with AML. Another important phase 2 study is a study from the NCI evaluating the combination of Cladribine and Rituximab in hairy cell leukemia. We had previous data, mainly from MD Anderson, demonstrating that the addition of Rituximab to Cladribine improved MRD negative responses and prolonged disease control and possibly cure. But the issue is that Rituximab was given after Cladribine, and based on preclinical data, the synergy of these agents occurs mainly when they're given together. So this phase 2 study evaluates exactly that, the concomitant use of Cladribine and Rituximab versus Cladribine single agent, followed by Rituximab in patients that did not achieve MRD negative response. And what we see is that indeed, the concomitant use of Cladribine and Rituximab improves responses, more MRD negative responses, and improved progression-free survival. Patients that receive Rituximab after Cladribine could still achieve MRD negative response, but still the progression-free survival was shorter, demonstrating the importance of this combination given concomitantly. So both agents are used very frequently, and I'll very likely consider using the combination the next time I treat a patient with hairy cell leukemia. Another important study is the NSTOP, which is a study that evaluates the use of nilotinib or the interruption of nilotinib when given a second line after imatinib failures. This is a longer follow-up of the study, has previously been demonstrated or presented in numerous meetings. This is a long-term follow-up at 192 weeks, demonstrating no significant change in what we have seen previously. Most of the patients that remained treatment-free continue to be treatment-free. At approximately 45-50% of these patients were able to stop the nilotinib and not restart it. There are no new toxicities, no new recurrences, and one important feature on discontinuation of TKIs, which is joint pain, no significant change over a longer follow-up, with the same joint pain seen was slightly decreased incidence compared to the previous evaluations. On Sunday, we had the myeloma session. There were three very large phase 3 studies that have a direct impact on what we do with myeloma today. The first was the study Forte, evaluating one frequent question in myeloma, which is the use of consolidation autologous stem cell transplant in the current era where we use newer agents as part of induction. So in this study, one group of patients received KRD, so carfilzomib, lenalidomide, and dexamethasone for 12 cycles, while the other group received 4 cycles of induction with KRD, followed by transplant and consolidation with KRD. One very important feature of this study was that patients were subdivided or evaluated according to the ISS score. And what we see is that patients, mainly patients with high-risk ISS, ISS 2 and 3, were the ones that benefited from transplant. So one way that this was evaluated was by early relapses. We know that higher-risk patients tend to have shorter disease-free survival, and indeed, transplant allowed for improved rates of progression-free survival mainly for patients with high risk. Those patients with ISS score of 1 did not benefit as much from transplant, suggesting that we may start to evaluate which patients we may consider not utilizing transplant in the first-line setting. Another very large study was the study Cassiopeia, evaluating daratumumab addition to a triplet, in this case VTD, now in patients with that were transplant eligible. Why do I say now? Is because we had already data on the benefit of addition of daratumumab to transplant ineligible patients. So in this study, daratumumab was added to VTD in patients that were transplant eligible, and what we see is that the addition of the monoclonal antibody improves progression-free survival, improves response rates, and certainly suggests that this combination should also be considered in every single patient that we're treating today for multiple myeloma in first line. And another not practice changing, but a study that will definitely have a direct impact on how we treat myeloma is the study Columba, evaluating the use of subcutaneous daratumumab instead of IV. We know that one of the main problems with daratumumab is the infusion-related reactions and also the very prolonged chair time. So the subcutaneous formulations helps but minimize this issue. And what we see, this was a non-inferiority phase 3 study demonstrating very similar response rates between both methods of administration, but significant decrease in chair time from at least 200 minutes with daratumumab IV to around 5 minutes, and significant decrease in infusion-related reactions. So the moment that we have this formulation available, certainly we're going to be using more and more of this. And last, on Tuesday, we had the lymphoma session and 3 very, very important studies that certainly will have impact on what we do today in the treatment of lymphoma. One study is the AATR, evaluating a very important question in the treatment of T-cell lymphomas, which is the comparison between autologous and allogeneic stem cell transplant as consolidation after first-line therapy. There are some lymphoma experts who believe that these patients, whenever possible, should go straight to an allogeneic stem cell transplant because of their very high risk of relapses after first-line therapy. So this study was a randomized phase 3 study. Most of the data comparing transplant and T-cell lymphoma is retrospective data. Approximately 100 patients, 50 patients per arm were treated. And what we saw is that, as commonly seen in T-cell lymphomas, there's a large group of patients that didn't even get to transplant because they had relapses shortly after the first line of therapy. But for those who did, allogeneic transplant reflected as what we usually see in this comparison between autologous and allogeneic stem cell transplant. More relapses with autologous transplant, but more treatment-related mortalities with allogeneic stem cell transplant, reflecting very similar long-term outcomes, similar progression-free survival, similar overall survival, suggesting that as a rule, we should probably stick with autologous stem cell transplant as first consolidation and leave allogeneic stem cell transplant for a potential second remission in patients that relapse after autologous. Another important study was the Vaughan study, which answers an old question that now is not as important, but is still very nice to see this type of data in a large phase 3 study. This study has 2 phases. The first phase tried to answer the question of whether rituximab given in more intensively as part of R-CHOP improves responses, and that data has already been presented and didn't demonstrate any benefit from adding rituximab to R-CHOP or additional dose of rituximab to R-CHOP in the induction. And now we see the second part of the study, which is the evaluation of rituximab maintenance as part of a treatment of large B-cell lymphoma after responses to R-CHOP. And what we see is absolutely lack of benefit from the addition of rituximab maintenance. And last, another very important study evaluating a fixed dose of venetoclax and obinutuzumab versus obinutuzumab and chlorambucil, what was the CLL14 study. The importance of this study is that it goes against our typical idea of chemotherapy as being the fixed those regimen versus oral agents that are given without interruption. So this study evaluated a fixed dose of venetoclax and obinutuzumab for a total of 12 cycles and compared that to obinutuzumab and chlorambucil. And this presentation given at ASCO focused mainly on MRD and also progression-free survival. And what we see is, as we expect, much deeper or much more frequent MRD negative CRs with the combination with venetoclax compared to chlorambucil, but also improvement in progression-free survival, which is what we typically see. MRD negative responses reflecting in longer disease control, but demonstrating that this is possible even if you discontinue venetoclax after a period of 12 months. So suggesting that we may really start considering more and more discontinuation of these oral agents in patients that achieve a solid MRD negative CR. Thank you.